Here on a beautiful island in the Salish Sea, it's hard to imagine the burden of malaria half a world away in Uganda. In this beautiful country, 36 million people live, work, write emails, hug their kids, and if they have the means, indeed struggle to enter the digital age. Winston Churchill called Uganda the pearl of Africa for the friendliness of her people, and the country is proud to contain the headwaters of the Nile River and the largest number of wild mountain gorillas on the planet. But it also has the unenviable distinction of the world's highest malaria transmission intensities. Living in the first world means that certain interests associated with our society disproportionately structure the landscape of practical possibility for many, many other humans. What do I mean? I mean, we live in a world where social media is worth billions of dollars, but the world's emergency food program goes $500 million short every year. Last year, Facebook acquired WhatsApp, a social messaging app, for $19 billion. $19 billion. $6 billion a year could end the suffering of millions from malaria. And Africa actually loses twice that much, fully $12 billion a year in GDP loss, productivity loss due to malaria alone. But money is not really the problem. The problem is that money attracts creative attention. Where your treasure is, there your heart will be also. And with a prize like that hanging out there, it's only natural that the best and brightest software engineers are busy in their garages trying to create a billion-dollar app. And that's unfortunate in a way because many of us find it more rewarding to work on problems that matter urgently to other people. Just imagine if all that energy were directed towards finding a solution to world hunger or infectious disease. It doesn't take much to shift focus. Sometimes all it takes is having a friend who is intimately acquainted with people who struggle every day to have enough to eat or who are continually ill. I run a Ugandan organization, and fiscally speaking, we're small. We don't have the billions that it takes to defeat malaria in Africa by ourselves. But we can use our resources to do demonstration projects, operational research projects, engage larger partners, and hope to affect malaria control policy. As a rule, we're scared of snakes and sharks, but it turns out that mosquitoes are the world's deadliest animal, more deadly than ourselves with all our war and homicide, because they contain the malaria parasite. Malaria is a completely preventable, treatable disease which kills over 700,000 people a year. The parasite spends part of its time in mosquitoes and part of its time in humans. And mosquitoes catch malaria from humans, and humans catch malaria from mosquitoes. And that's important because defeating it means drawing down those parasite intensities in both species. Malaria has actually been with us for thousands and thousands of years. The ancient Egyptians had bed nets. And indeed, if we look at the death toll through history, half of all the people on the planet may have died of malaria. But those can be kind of meaningless statistics. I have a colleague in Uganda, a doctor who works in public health like me, Dr. Lugemwa, and he and his wife had a very bright son, one of the sharpest, and they invested in sending him to the best school in Kampala, very expensive. And when he was 17, studying for his university entrance exams, he got malaria, and it progressed and crossed the blood-brain barrier and became cerebral malaria, which is 25% fatal. He was lucky, and he didn't die, but he did emerge from his illness unable to read or write, and he will never go to university. Or last year, when I was traveling to a project site, I met a young mother of 3, Joyce Nabweri, who showed us the 2-week-old grave of her 6-year-old son who died of malaria. But the thing that broke my heart was to see that Joyce and her 2 remaining children were sleeping under a cotton bedsheet. She reasoned that since a bed net had not protected her son well enough, what she needed was a more a more solid version. So here it is a stifling hot climate, and she's sleeping under this thick, opaque sheet. Uganda has a truly staggering burden of malaria. In the last 65 years, we've eliminated malaria from all the rich countries in the world, and now 90% of the burden is in sub-Saharan Africa. But fully a tenth of that burden in terms of death and disease is in the country of Uganda, and it's the size of Oregon. So these stats are a little old, and the deaths have reduced somewhat, but the burden is, the number of cases is that high. And in per capita terms, in US terms, it's as if 500,000 children were dying every year of a preventable disease, and 160 million more were falling ill. Malaria affects everyone in Uganda, even middle-class families like the Lugemwas, but the burden falls hardest where the health system is weakest, on the rural poor. And that's because treatment is very effective if you get it in time. It's when the disease progresses that it becomes fatal. So if you're wealthy, malaria doesn't usually kill. And that means it's not getting the attention and the funding that it should, even within Uganda, because unlike HIV/AIDS, which is an equal opportunity disease, malaria is a disease of the poor, and the people it affects the most are the ones with the softest voices, the quiet people. And this is a kind of a tragedy, because international donors are only putting in about a third of the resources required to combat malaria. And even that third is not being spent as effectively as it could be. So the malaria community is getting very good at taking countries with very low transmission rates over the line into national elimination, no malaria within the national borders. But techniques for taking countries with very high transmission rates and reducing them to low transmission are not strong enough. A good, careful study over the last 7 years showed that malaria is actually rising in many places in Uganda despite the universal distribution of bed nets. Deaths have reduced due to better management at clinics, but the number of cases is very high, and that's a problem because severe malaria, even if it's non-fatal, causes cognitive damage. So my story, in 2007, when I was studying the physics of molecules at the University of Washington, my Ugandan husband and his friends asked me to help them design a program that would drastically reduce malaria in a rural community. They knew from living in the community, and this was over a decade ago, that malaria control techniques weren't working in Uganda, that techniques to reduce infections from 50% to 40% weren't dramatic enough to engage the community, but they weren't doctors or scientists. I wasn't a medical doctor either, and I didn't know anything about public health when I started, but I did have a kind of inchoate desire to help this wonderful Ugandan organization with a huge heart. So I sat down, as a physicist will, with first principles and said, okay, what tools do we have in the toolbox? There are two main types of malaria control: preventing mosquitoes from biting humans or reducing their numbers, and treating people. None of these tools works well in isolation, so bed nets alone aren't going to be successful. What suppresses infection is a combination of interventions from both these categories, and different tools work better in different transmission regimes. So one of the best tools for high transmission mosquito control is indoor spraying. It avoids putting pesticides into the environment, as we did here with DDT, and instead applies them to hut or house walls where they protect inhabitants as they're going about their evening activities and not just while they're sleeping, because after all, it's hard to live life wrapped in a giant bed net. But it only addresses the infections in mosquitoes. It does nothing for the infections in humans. And for that, you need medical management. And here's where we didn't think and don't think that the methods currently approved by the World Health Organization are strong or effective enough for high transmission areas. We worked together with the Ministry of Health And we chose a mid-sized region, 150,000 people. Half the kids in that region had malaria. So we piloted a new approach. We combined spraying with presumptive treatment of all the children, which cured those children that were ill and prevented all the children from getting malaria for a month. Spraying was an approved intervention, but not at that time used in rural high transmission areas. And presumptive treatment had been used in several places, but it was a little more envelope pushing. We reasoned that by doing both of those things at once, we could draw down those parasite reservoirs and have a big impact on transmission. We had great results. We reduced over 80% of the clinical cases, and the pediatric ward in the main hospital emptied. The community was thrilled. The Ministry of Health was thrilled. But we got a little pushback from international partners in country. They complained that we'd spent too much money, that spraying was expensive and logistically difficult. They said we'd raised expectations. Well, frankly, that was our hope. But I take the complaint about expense seriously. So in the state of Florida, we spend about $8.40 a person on mosquito control. This is nuisance control because there's not a single case of human disease transmitted by mosquitoes in Florida. In Uganda, spraying cost us just a little more than that, $8.70 a person. So it's hard to understand why it's worth doing here, but not worth doing there, where people are dying. These days, I'm happy to report things are different in Uganda. Both USAID and DFID, the UK version of USAID, are funding indoor spraying in rural high transmission areas. And the official Uganda malaria reduction strategy calls for the spraying of 40% of the country, 50 districts. So no one tells us that anymore that we're raising expectations by promoting rural spraying. Presumptive treatment is still considered a bit more radical, but there's growing interest in that for reasons that I'll explain. We are trying to figure out how to go on the optimal path from high transmission to very, very low transmission. And we define that optimal path as fastest, safest, cheapest, so that we can get the biggest impact for the health investment. So to look at what the effect of interventions might be, we do computer modeling. This is a simplified simulation of what happens if you do spraying and then stop. On the left are the percentages of the population that are infected with a detectable number of parasites. They'll test positive for malaria. And the blue line shows what happens if you do nothing. Over 8 years, 50% of the people are infected. And the red line shows the impact of 2 years of spraying. It's very effective in the short term, but as soon as you stop, the malaria rises again. And this is actually happening in the country right now. There are limited resources available for malaria control, so 50 districts need spraying, but USAID can only afford to spray 10. Caught in this bind, they decided last year to move spraying out of 10 districts in the north where they had been spraying to 9 new districts in the south. They hoped that bed nets would hold the gains made by spraying, but bed nets are a less powerful tool and they're not working well in Uganda right now. So I showed you here what happens if you stop spraying, and unfortunately that's happening now. This is not simulated data. This is real case numbers from one health center in those 10 districts, but this same trend is going across the whole region. This represents 3 million people. Cases are rising very fast, and it's big news in the country. People are dying because the explosion of cases wasn't predicted. And so there are medical shortages at these rural clinics, and malaria kills very fast if it's not treated. So we want to help funders and policymakers have really practical, effective solutions. And in our upcoming project, I realize this slide is very busy, bear with me. we're going to be doing a lot in the first 2 years. It's a cocktail of interventions. First 2 years, we use spraying and treatment together to crush the clinical cases. Then we remove the spraying and the treatment, but malaria doesn't go back up again because we introduce a second medical intervention. It's community-led case detection, where health volunteers from the village go house to house, finding folks who are sick and testing and treating them on their spot. It was actually pioneered by the Peace Corps in Senegal and called PROACT, and it's very low cost and sustainable. It's the kind of program the national government can implement, and it holds the malaria down at least for a few years. You may have to come back again and add another spray round or two, but you don't have to do it as frequently. So you can see that this sequence of interventions is slightly more expensive in the first 2 years, but it's much less expensive long term, and it allows you to sustain malaria at a very low level. So if USAID and the government of Uganda decide to combine spraying and treatment in a regimen like this, we think they might be able to double the number of districts that are effectively controlled with the same investment and remove a lot more malaria than with spraying alone, and create a new status quo in which there are very, very few people getting sick. So human beings are extraordinary. What we choose to focus on, we can accomplish in an amazing way. If we want to go to the moon, we can. If we want to run cars on hydrogen fuel, we can. And if we want to end malaria, we can. This is an era in which people are wondering, does aid work? Can we ever plug the black hole of need? Should we even try? Well, what we know doesn't work is aid combined with shoddy attention. What can work is our resources together with our best attention. And our best attention is more than our resources, more even than our brains and our talents, though it includes those things. Our best attention is when we honor one another and dedicate ourselves in service to one another. In this case, for the sake of those quiet people. If we can think of their good as the treasure, we can invest in that moment when they say, malaria can be beaten. We don't have to suffer like this anymore. Enough. Do we have to be wary of the desire to rescue and our colonial assumptions, even as providers of public health? Absolutely. But we can't shrink back either from trying to make a difference. There's a Swahili word we love at Pilgrim Africa, jasiri. It means courageous. Let's all be jasiri in imagining one another's good. Thank you for your attention.